let me start off here by saying today we want to talk about the end of life care, especially with the focus on COVID-19. We want to discuss special circumstances related to advanced care planning, review some of the tools that are available to us, and finally, that point that I was making about how to determine decision-making capacity. Next slide, please. Yeah, so this just came out recently, and I think if you look at the left-hand column here, you'll see pretty much a pictorial description here. You know, these kind of shadow figures. At the top green, you can see the upright, standing man, and then going to a little more vulnerable older adult with the cane, and then progressing to mild frailty with the rolling walker. And then the next level of frailty, needing some assistance for transfer and walking. And then finally, the severely frail individual who is either bedbound, wheelchair bound, or very limited in both cognition and body function. And so what we can see is this graph that shows the time after admission to a long-term care facility, in hospitalized patients, that looks at their survival probability. And I mean, it's just amazing. Each of these categories, it goes green, blue, gray, right on down the line here. So what the obvious impression here is that the people that are severely frail really have a huge mortality rate, only 25% survival rate, right? So we're going from basically a 70% survival rate down to a 25% survival rate. So right then and there, this data shows us that if we understand the activities of daily living and what the functional status of our nursing home residents are, we can say with some fairly strong certainty here that people that are severely frail, those that need, for instance, transfer assistance or mobility assistance or other ADL assistance, that those people really have a very low probability of survival. And so I think that we need to use this kind of information, and you're welcome to use this graph to show people, where your residents are. It's like I say, it's a very pictorial essay that helps with the discussion about really whether it makes sense to go to the hospital or not. So I just wanted to have this visual slide here that helps represent this concept that there are different degrees of frailty, and as people become increasingly more frail, the likelihood of their surviving a hospitalization, even whether it's from COVID or not, they still have a very high mortality rate. Okay, next slide, please. So part of this is to prepare for advanced care planning. We recognize that it can be uncomfortable for patients and families, particularly if they haven't talked about it. It's on both ends, asking if, an individual has thought about their end-of-life care plans. I mean, we had that discussion in my geriatric clinic here just the other day of somebody who had what we call idiopathic pulmonary hypertension, and she just was getting more and more short of breath. And we transitioned into low-dose morphine therapy for her to relieve her air hunger. But interestingly, both the patient and the daughter were not really recognizing the fact that this shortness of breath was associated with a terminal prognosis. So sometimes it's important for us to share prognosis with individuals. We'll see a little bit later in this presentation that the understanding of life expectancy amongst patients and their family members is often twice that what a healthcare worker might actually consider. And so there's a big gap in older adults' understanding of their life expectancy. So that's the second point here, that they're just not aware of how much remaining time they might have. Okay, next slide, please. So part of the problem with COVID, as we know, it can be the complications can be sudden or they're progressive. Also, we need to talk about the survivors from nursing homes from COVID, and whether the post-COVID syndrome is affecting them. And the data so far suggests that of those who succumb to COVID, a third of them have a sudden course, but the vast majority, 2/3 of them, will have somewhat of a what we call a more gradual or indolent course towards death. So, an important tool that you can use, and I encourage you to use this, is this ePrognosis website. It's hosted by the University of California at San Francisco. And you can look up, life expectancy. Some of these things, after you do this after a while, you sort of know what the numbers are. So if somebody lives to the age of 81 without any functional disabilities, there's a good chance that they'll have 7 to 8 years of remaining life expectancy. However, if they have, like a nursing home resident, some functional disability, that predicted lifespan of an 81-year-old may be more like 2 to 3 years. So that's important to know. And then the final point is that there's a 20% mortality for 80 and older. I mean, it's just fascinating that the 80-year-old is the cutoff. It's not 78, it's not 76, it's an 80 and older that seems to be the cut point for this really unfortunate mortality rate. Next slide, please. So I think it's also important to recognize the fact that patient preferences or residents' preferences will change. So we know that functional declines occur in long-term care facilities. These are a natural course of people's chronic conditions, disease, or dementing illnesses. These are not due to nursing home neglect. As a consequence of these gradual declines, it's possible that people's preferences for what they want done as an intervention, given the fact that there may be no reversibility of their condition, they may then have a recognition that comfort care is more important than acute care. Now, the other point is that this Hopkins study found that 90% of people who were conscious, they were able to talk and give feedback in the emergency room, changed their advanced care directives. If they were of those who are not able to speak for themselves, their care plan or their advanced care plans were often implemented as they had written down. But the important point is the last point here, is to know when comfort care is really the only realistic option. I think folks may know that pretty much 85% of all Medicare costs are attributed or aligned with the final year of life for most Medicare recipients. So we spend just an inordinate amount of money in the final year of life, which is totally futile. So that raises the whole question of, do we recognize these people where comfort care is really their best option? Next slide, please. So I think there's a way to think about this, and this comes from the Institute for Healthcare Improvement, which is kind of new for me from a geriatrician's point of view, because what they did is they broke this down into 3 categories, right? So you've got the prolongation of life. So those are interventions, usually acute care interventions if they occur, that you want to implement to try to prolong life. And a good example would be utilizing antibiotics, intravenous antibiotics for pneumonia. And then there's a group of patients where you want to maintain function, but they're not necessarily going to get better. These are people that you want to try and keep at independent as possible. If we think about those different colored pictures, probably the first 3 would be the type of people that we would want to maintain function on. And then as we go into those final 2 categories of severe or advanced frailty, this is where we want to think about comfort care. Okay, so that's really improving the person's comfort as a means to strengthen their quality of life at that particular moment, and that includes things like managing pain, managing distress, and managing really the realization that they are coming to their final moments. Next slide, please. So interestingly, the odds of surviving CPR, and this may not come as a surprise, but they decrease with increasing age. And so basically when you're doing CPR on a 90-year-old or older, there's just about a 10% chance that they'll survive. And this is in the hospitals. Okay, this is not, well, we'll see shortly. It's only 3% in long-term care facilities overall. But just look at the odds. So, again, this is a point of discussion for older adults and their family members that, based on age, and of course, the survival is even worse or worsened if they have severe disabilities or are frail. Next slide, please. So here's another distribution of survival odds in critical care, focused specifically with COVID. Okay, so you can see that there's a for those that are in the ICU, that a quarter of those individuals who are young will die. But then look at what happens as you get middle-aged adults. It's about 50-50 chance. And then if you're 70 and older, you're basically talking about 70% of those people who go to the ICU are going to pass away from COVID. So again, these are all talking points for, and these, by the way, are not data for people from nursing home residents. When you talk about 70-year-olds who end up in the ICU, you're talking about all 70-year-olds coming from 70 and older from the community as well as in the long-term care. Next slide, please. So we want to consider these the medical orders that are reflecting the resident's preference. So basically, it's that's where the POLST comes in, the physician order set. So it's important to have these documented. We did a study in our clinic, and we only have 50% of our patients documenting their code status, and so we really have a lot of work to do, quite honestly, in the outpatient setting. Next slide, please. Yeah, and then I alluded to this a little bit earlier about the CPR survival. So one study found that CPR in nursing homes doesn't work so well. Again, this is not an indictment on the nursing homes. It's rather a reflection on the fact that you're dealing with people who are really in the final phases of their lifespan, and their bodies just cannot respond to resuscitation. Next slide, please. So some of the goals for CPR are primarily prolonging life. And so, if you find these people that are, or residents that are in that category where it's really important for life prolongation, CPR should be part of their portfolio. So these would be people that, for example, that come to the facility for rehab for hip replacement or knee replacement, and they're otherwise pretty high functioning. That would be a reason for doing CPR. On the other hand, you've got this group that either you're going to just maintain function or you're going to provide comfort care. Really, there's serious consideration should be given to not to have resuscitation for those individuals. And so again, those need to be in alignment with what the patient's wishes are, but also through an informed discussion as to what really expectations are. And again, I had a nursing home resident, younger fella, who was blind from infections in his eyes. And I asked him what his goals were, and he said, "Oh, I want to see again and go back to work." And the idea of the guy going back to work was a possibility, but the idea of him seeing was just a totally unrealistic expectation. So I think it's just important to match what people's expectations are to what we know as healthcare providers as to what the reality is, and to engage in that conversation. Next slide, please. So the question is, what about do not hospitalization requests? Just in the chat box, has anybody used these as a order on their residents? Do not hospitalize. Just put yes or no in the box. Yes, very good. Okay, so I think those are important to know, that people are using the do not hospitalize requests. And I hope they're being honored, because in my experience, I often would get a phone call, we transferred Mr. So-and-so to the hospital, and I said, wait a minute, we put a do not hospitalize request there. And then they said, yeah, but we called the daughter, and the daughter said, to send him to the hospital. And I go, well, but it wasn't the daughter's decision. It was the resident's decision. So anyways, you know what I'm talking about. There's always this, line of communication that gets disrupted as part of this process. Next slide, please. So again, the hospitalization needs to look at the goals of care. So, excuse me, we have the prolongation of life on the left side, where hospitalization seems like the right idea. On the converse of that is that if somebody's primarily focused on comfort care, I think it's pretty clear in our thinking that those people should not really go to the hospital. And it looks like most of the facilities have this as part of their consideration. But then is that middle zone, the gray zone, sort of what I put as the plus minus sign. If the goals are focused on maintaining functionality, some of those people may have hospitalization. So it's really a judgment call in these individuals. But nonetheless, I think it's important to really, at least formulate that comfort care group and identify those that are more the prolongation of life group, which again would be those people that are going to the skilled nursing facility for rehab purposes, with the expectation that they'll be going back to the community. So I think that may be one way to think about it. If the expectation is that they're going to go back into the community, that they should be in the left-hand column. And if the expectation is that they're going to be a lifelong resident, they will then, of the facility, then they will either fall into that middle category or to the comfort care category. Okay, next slide, please. So again, if the goal is comfort care, should avoid hospitalization. Ideally, this person should be treated in a COVID unit at the facility. And there's nothing wrong if you can get them the monoclonal antibody cocktail. That's perfectly fine. But again, the idea is to share whatever we're doing, to share the treatment plan with the resident as well as with the family member. Okay, next slide, please. So this is a really telling graph of what happens with older adults who are frail. So part of the issue we have going here is that there's just a steady decline, and with each hospitalization, the older adult loses some level of function. You can see that in the first part of the graph. They recover, and they don't quite get back to where they were before. Technically, your MDS should reflect that. And if you ever did a graph of all the people that were hospitalized in your facility, you would probably end up replicating this graph, for each hospitalization. So frequent hospitalizations, even if they weren't for COVID, if somebody's bouncing back to the hospital, that's a very strong indicator that they're on this trajectory, and rapid trajectory towards towards death. So again, we have to look at whether the hospitalization is going to accomplish the goals that we want. I mean, I can't tell you how many times I've had patients recycle from nursing home to hospital, and to be perfectly blunt, it just was a relationship between the facility and the hospital that was more, I think, financial than quite honestly in the best interest of the patient. So we need to think about, exactly what the quality of life is of the individual, being mindful of this trajectory, okay, and actually educating family members about these types of trajectories, that they're not necessarily going to recover or get better. And this is particularly true of the Alzheimer's patient, that once they start having a functional decline, there's no recovery. And I had a very I want to say a strong debate with my geriatric nurse practitioner, whose mother who had Alzheimer's, and she was just a very loving daughter, and said, "Oh, they're not giving her any rehab." And I said, "Well, it's because she's not going to recover." She says, "Well, she's got 100 days benefit, so I want her 100-day benefit." And it was just, it was a point of view. You want to do everything for your loved ones, but sometimes there are these moments where there is a fairly strong certainty that they're not going to recover or get back to where they were before. So this graph illustrates this in that respect. And sometimes showing family members this type of graph is helpful. Again, I like to use visual aids to try and tell the story. Dr. Dahl, are you able to take over from this slide?
Sure, I can.
All right, good deal.
Sorry,
good
issues in the clinic today.
Yeah, no doubt, no problem.
All right, so let's see, I gotta figure out where we are here. Documentation, I'm guessing, of advanced care plans is what we're talking about today. So obviously we want them easy to access, and we want them to travel with them when they go outside of the facility is the most important thing. So they always have to accompany the resident wherever they're going, to any visits, to the emergency department in the ambulance, so that we can do what they wish wherever they go. Next slide. Obviously, you need to have the information for the proxy and healthcare representative on there so that that person can be contacted. Next slide. Document tools. So there's certainly two different kinds of documents that we have. And one is the advance directive, which is a legal document that the patient fills out with their healthcare proxy that assigns a healthcare proxy and a legal representative or power of attorney, and then describes the wishes of that individual person. And so it's their wishes laid out in an official document. And the other type of thing we have is actual medical orders. So those are the pulse or the DNR orders that you guys have people fill out in the nursing homes or assisted living. So those are actual medical orders that are saying these are things we are doing or not doing. So that's kind of a little bit of a difference between the two. The pulse is also wishes, right, of the patient. And so it's kind of the orders that reflect what the patient may have said in the advance directive. Next slide. I think the pulse and the medical orders are an important thing to do in nursing home patients or other people who are kind of at the last stages of life, right? So who are more frail, who have chronic illnesses. That's the time that you should be considering the pulse and orders. So what matters most? We want to establish their priorities for what they want done to them. I always ask, what matters most to you? What makes life worth living? And to try to dig a little bit further, I always ask, what brings you joy each day? Sometimes you can get a little bit further in what matters most to them by asking, what are you willing to live without, but still think that life is worth living? And so those are some questions that help get to what matters most to them. So some of that is, do I want to go to the hospital and have everything done? Do I want to stay at the facility and have the things done there to keep me comfortable? Next slide. So here's another picture of kind of the difference between the orders, like the PULST is, and an advanced directive. So, advanced directives, we're recommending 18 and older all fill out and should have on hand, where the PULST should be for those with the multiple chronic diseases towards the latter stages of life. And just the difference is, so the patient completes the advanced directive, and it's the healthcare physician or providers who are interpreting the advanced directives into a PULST. And so, you know, who's responsible, providers versus family. Next slide. So here's an example of the PULSE, one of PULSE. There's certainly, each state has a little bit different variation, or there's kind of the national PULSE. And most of them, you know, have these kind of three stages where it's comfort only, limited interventions, or full treatment. Some of them go into, like the North Dakota, I think, goes into nutrition. So we'll talk about nutrition and IV fluids on there as well. But so those are kind of ways that they vary. This one does that as well. It says administer fluids, no artificial nutrition for a defined period of time, or please do it all, you know, do it. We want all that done. So I think these are great. I encourage and recommend the PULSE. I think they're the best thing to do in the nursing homes, and I'd hope that we're kind of pushing that form. Next slide. So these are just kind of other questions, how to get out of the family, what wishes might be. And it's hard to know because most people fill out their advanced care directive, and I can tell you, most people say, I want CPR and be ventilated if a reasonable outcome, right? That's kind of the terminology that everybody uses. And so I think it then becomes the medical personnel who has to interpret, well, what's a reasonable outcome. So you have to learn what are the values and the wishes of the patient, what matters most to them, what means valuable life to them, and what are the chances that doing these things are going to end them up in one of those positions, right, that they do or do not want. And so I think you have to dig down and keep asking them questions and to try to figure out what's most important to them. Next slide. Decisional capacity. So this is always a sticky subject and hard to sometimes understand. And I think it gets us in a lot of problems, especially when somebody is transferred from a facility and gets into the hospital, and then they're required to ask them right in the emergency department, you know, what are your wishes? Do you want us to do CPR? And so they obviously say yes, because they're in this, you know, they don't feel well. And of course you want everything done. If you can't breathe and you're scared, right? And so, and are they in the right state of mind, or do they have decisional capacity in that moment? And I don't know that we do the best in those situations, and we probably don't. I think that's why it's important that they see what decisions had been made when the patient wasn't in an acute crisis situation, because we should go by those things rather than what they're saying in this acute moment, right? So that we're actually going by their wishes when they're of a sound mind. But does the patient have decisional capacity? And that's you know, capacity can change from moment to moment, and it, you know, the questions you have to ask are, can they tell you what the situation is and what their illness is and what the outcomes are with various interventions? Do they understand that, and can they report back to you and describe what's happening? And then are their decisions made off of values that they've been consistent in their life to that date? So like, those are some things you need to think about when you're considering capacity. A lot of people in the nursing home do not have capacity on a regular basis. Next slide. And then we have to go with their proxy and have those discussions with their families, right? What goes into their decisions about medical treatment? Quality of life at the time, the things that they enjoy, emotional impact on family is a big one. And I think the biggest one is, can I have meaningful conversations with my family? Can I make decisions for myself? So cognition goes into a lot of decisions, which I think makes sense, right? All of us would think life is worth living if we could think clearly and have reasonable discussions and interactions with our family because our mind is intact. Decision-making abilities, understanding, appreciation, reasoning, and communicating a choice. kind of what we talked about. So Case here.
Hey, Dr. Dahl.
Yeah, are you going to jump in on this?
Yes, ma'am. This is
Perfect, thank you.
continuation from last week. Before we go into the case study, we'll review what it was from last week and then what we're going to discuss today. But I just wanted to touch base on a couple of points that Dr. Dahl and Dr. Juravich made, which was on the code status. Take this as an opportunity to evaluate whatever your audit system is for code status. That is an area that can get you in lots of trouble if you have a full code documented in one place, excuse me, and a DNR documented in another place. I can say in the past, our routine in facilities that I worked in is that our social worker always verified those orders as they came through on a daily basis. If someone was changed to a DNR status, checking all of the locations that you may mark it. Then number two, always verified that everything was appropriately marked during care plans on a quarterly basis. And lastly, at minimum twice a year, we did 100% audit of code statuses. I think that unfortunately it can be one of those things that slips through the cracks or you miss, and that could be a detrimental outcome if you do not have the right status posted or marked on their medical record. And unfortunately right now, you have so many places to mark it because most people still have some sort of paper chart of some nature. You have an EMR system, and then you may have a CNA care plan only for CNA's reference, and then a full care plan. There's different systems in place to help communicate these changes to the staff, and you just want to make sure all of those boxes are checked. So I just wanted to throw out that quick reminder that you can, there's an opportunity for an audit and see if there is an issue, and if so, you can consider doing a PIP related to that too. Being proactive instead of reactive. That's the message behind the difference between quality assurance and QAPI, is that really we're trying to be proactive now instead of reactive. Okay, and just a quick reminder, as we discussed the case study last week about an outbreak of COVID in the facility, and it was determined that their screening policies were unreliable and that the team was going to initiate a performance improvement plan to improve the screening policies in order to prevent additional or subsequent outbreaks. I think we have a poll. Give everyone a couple of minutes to do this poll. And while we're getting answers on that code status again, also look at how soon that you're evaluating what their wishes are when they enter the facility. When you do that 72-hour or that initial care plan, that should really be on that check sheet. Okay, the first step in developing a PIP following your root cause analysis, yes, is you need to develop a goal. Now that you've determined the root cause of your issue, then you need to hold yourself as well as your team accountable to correct this issue and to start that path of writing your PIP and selecting interventions. It's imperative to have a goal in mind. Which of the following is not necessary in a SMART goal? Yes, absolutely. The majority did say it must include training. Training could be used in a SMART goal, but it is not a required piece of a SMART goal. And the following goal is a SMART goal, ABC. Nursing home will reach 100% compliance of hand hygiene by training staff on hand hygiene procedures and policies using a return demonstration. The majority did select true, but the one thing that this example is missing is time bound. We have no time frame that we want to complete this goal. So since maybe you got the hint from the poll questions, but we're going to talk about SMART goals today. So, okay, a SMART goal. SMART is an acronym for the different pieces of a goal that you want to include whenever you're completing a performance improvement plan. And the first one is S, which is specific. Make sure your goals are clearly defined. Who will benefit from the goal? If you can ask those 5 W questions. What do I want to accomplish? Why is this goal important? Who is involved? Where is it located? Which resources? I know you guys probably are sick by now of me saying those 5 attributes and those 5 W questions, but it's very important to get down to the bottom of what you're intending to accomplish here. We'll go to the next slide. Measurable. I know on the poll that was something that that had popped up, that it didn't have to be measurable. It is important that it is measurable, because you can't show that you're making any progress or that the system you put in place is reliable if you have no way to measure its outcomes. Quality improvement in general is data driven, because you need to be able to see your progress or the improvement that you put in place. So measurable goals provide direction to your team and allow them to see that progress and document it. Something I encourage folks to is that whenever you put a PIP in place, have some sort of display for your staff who are all working hard towards this, showing those outcomes and measurements in a visual demonstration to help encourage them to continue to focus on this project. And when they see it, you can use charts and graphs, you can use all sorts of images in order to show that progress. So your measurement can be about a certain number or a percentage of what data you're monitoring. Okay, the next one. And the next letter is A for attainable goals or achievable goals, but they need to still require effort. We don't want to ever set yourself up for failure. So look at the goal that you're putting in place and make sure that it is something that you and your team can achieve. So look at how you're going to accomplish the goal. Is it realistic? So I think we've got, sorry. Is it realistic, and is it something that you have the capability to do? If you say, hey, we need a new EMR system, and you try to put that in your PIP, well, that may not be achievable. You may not have the funds in place to actually put that in place. So make sure that it is something that you can achieve. The next is relevant. You want to make sure that your goals align with the team's stated vision, and that your relevant goal can answer these questions with yes. Does it seem worthwhile? Is it the right time? Does it match our other efforts and needs? During this pandemic, I know a lot of folks were putting plans in place on hand hygiene and PPE use and those focus areas. And the reason being is because it was the right time to do something like that, to really evaluate those systems. So whatever the performance improvement plan you're putting in place, make sure it's relevant at the time. Include that in your goal. Next, and finally, is time bound. Give yourself a timeline and keep it on track. And, you know, when we talk about performance improvement projects, we say keep them small and simple, as short as you possibly can, to obtain the data that you need to see if it's successful. But include that in your goal. I will reduce UTIs by 10% in the next 3 months by doing training with our staff on pericare, or whatever your plan is. But make sure that you can have a timeline there. And then the next slide, I have just a couple of examples of a SMART goal. In 6 months, we will decrease nosocomial infections by 25% by implementing hand hygiene practices. In the poll, one of the questions was about, does training have to be included in the SMART goal? And it doesn't have to be included, but if you look at that first goal there, chances are you're doing some sort of training on hand hygiene with your staff, but it doesn't have to be specifically stated in that goal. That's where we get to our interventions that we put in place after you've set your goal. The next example is in 3 months, we'll see a 20% reduction in employee shift call-offs by involving staff and scheduling. So this is what our plan is, and this is how much we want to reduce within this time frame. And then if we'll just, this is the last slide I have here on the quality improvement content. I just plugged this goal into the performance improvement plan that we've been tracking out over the past couple of weeks. So it's over screening for that COVID outbreak. And this particular goal reads, in 1 month, we'll reduce new COVID outbreaks by 75% by adapting screening policies and procedures. I know during the previous cohorts, we've talked kind of about that 75% number and that how it may or may not be realistic. And just to let you know, this is just an example. So I don't want you all to go back and say, well, I only had 3. It's going to be hard to reduce it by 75%. So just keep that in mind when you're looking at that. It's purely an example. And I will pass it back off to you, Dr. Dahl, unless anyone has any specific questions about that.
All right. Next slide. Do we have an end poll? We'll do this first. So advanced care planning is certainly an ongoing process that changes over time. If somebody had an advanced care plan from when they were 60 and now they're in the nursing home, it probably needs to be readdressed and changed and addressed with their new life circumstances. We can train staff to do this, and we should. It does take practice to become comfortable with asking people about end of life and death. We're a society that just doesn't like to talk about that. And I think it's important to get down to what matters most to those residents to help fill that out completely. And so some of those questions, like I mentioned earlier, help you kind of get there. And it's important to be honest about life expectancy and what the rest of the life might look like with their multiple chronic diseases and where they are in their stage of life. Next slide. There's lots of ways to help determine decisional capacity, lots of ways to help determine prognosis and length of life. So go ahead and use those. And I think we gave them earlier on, the ePrognosis and other examples of those. And yeah, you can create projects around what matters to help improve rates of advanced care plans that have been made and are accurate and done to the best of our ability so that we're doing to people what they would want. Next slide.